The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and welcome to today's webinar in the Public Health Webinar Series on Blood Disorders. This webinar is presented by the Division of Blood Disorders at the Centers for Disease Control and Prevention, also known as the CDC. I'm Dr. Victor Tapson. I'm Associate Director for Pulmonary Critical Care at Cedars-Sinai Medical Center in Los Angeles. I also direct clinical research for the Lung Institute there. I'm also a past president of the U.S. PE Response Team Consortium. It's really a pleasure to be here. We're delighted to be here to learn more about the multidisciplinary approach to acute pulmonary embolism response team. We're very lucky to have Rachel Rosofsky here today. Rachel's at Mass General, and Mass General is really where PERT started. So Rachel and her colleagues there are the founders of this concept. So we're very excited to have you here, Rachel. And by the way, she's also our vice president of the U.S. PERT Consortium right now. So great to have you. So just a couple of housekeeping and poll comments here I'd like to make. Before we begin, there's a few points. When you join the webinar, you'll see two audio options. You can opt to listen via the speakers on your computer or by using your phone to call in. If the phone option is chosen, the webinar toolbar will provide you with the phone and access number and audio pin. Now, all audio will be muted. At the end of the presentation, there'll be time for questions. And if you want to submit a written question, please use the questions area on your toolbar. You'll see it right there in your toolbar. Presenters will respond to as many questions as time allows. The webinar is going to last about an hour, about 35 minutes lecture or so, and then we're going to have the Q&A time. So please note this webinar is being recorded. And we're going to start with two brief audience polls. We're interested in knowing more about you, and also just want you to select your response to the poll questions now. So you'll see this poll come up in just a second here. Here it is right here. So which of the following statements best describe you out there? Healthcare provider and so on. And we've got more than 1,000 attendees today, which is fantastic. So I'll give you a few seconds to enter your answers and then we'll show the results here. There's most of your healthcare providers. We've got some public health professionals, some patients. Actually, patients are family members of DVTP patients. There you have it. And our industry partners. Put up another poll question here. It's going to come up here. So which region of the world are you from? North America or somewhere else? Let's see how diverse our group is today. Let's see who's listening in here. Okay, so mostly North America, but look, we're all around the world there almost. We have people from South America, Western Europe, Eastern Europe, Africa, Asia. This is great. Mostly US, Canada, and Mexico. Fantastic. Well, what I'd like to do now, Rachel, let me just formally introduce you if I can, Rachel. Rachel's Director of Thrombosis Research and Division of Hematology at Mass General Hospital, Assistant Professor of Medicine at Harvard Medical School, certainly an expert and leader in the field of venous thromboembolism, and her clinical and research interests and expertise really revolve around the evaluation and treatment of patients with this condition. She's on the board of directors of the National PE Response Team Consortium. As I mentioned earlier, Rachel's the vice president of the PE Consortium right now. So, Rachel, it's really great to have you. Welcome, and let's get started.
Thank you. Thank you very much, Vic. So, good afternoon, everyone. It is an absolute honor to be kicking off the CDC 2021 webinar series. And thank you, the National Blood Clot Alliance, for hosting us. And I will be talking about the multidisciplinary care for acute pulmonary embolism, the Pulmonary Embolus Response Team. Here are my disclosures. So I thought I would review the scope of the problem and then discuss the impetus behind PERT, description, how advancing science of PE care can be done through research, and end with discussing the PERT Consortium. I'm going to start with a case. This is a 27-year-old woman with a history of ocular migraines who presented with syncope. So on the day of presentation, she'd gone to the bathroom, washed her hands, and as she was walking back, she felt her vision darkening and woke up to her roommate waking her up. The roommate had actually heard her fall. Fortunately, after she woke up, she was not confused and didn't have any loss of bowel or bladder function. But afterwards, she was nauseous and she started to vomit. Now, of note, a week prior, she had left lower extremity pain and some mild swelling. EMS was called. Her heart rate when they got there was 140. Her blood pressure was okay, but she was tachypnic. Her respiratory rate was 32, breathing very heavily, and her oxygen saturation was 90%. When she got to the hospital, she had an elevated D-dimer as well as an elevated troponin, indicating that she was stressing her heart. Her EKG showed some sinus tachycardia with some non-specific ST T-wave changes. She had a bedside ultrasound of her heart to see if she was stressing her heart, called an echocardiogram, and it showed that the right ventricle of her heart was dilated and the right ventricular free wall was hypokinetic, and that's all consistent with acute RV strain. Fortunately, her head CT showed no evidence of any bleeding. I'm going to show you her pictures here. You can see that she has a saddle PE, where the arrow is on the right, and then she has a significant clot burden, both in the right and left main pulmonary artery. And on the bottom, she also has CT evidence that she has right ventricular dysfunction because the ratio of her right ventricle to the left ventricle is greater than 1. So how should this patient be treated? Should we treat her with unfractionated heparin, low-liquid heparin? Does she need systemic thrombolysis? How about surgery? Does she need catheter-directed thrombolysis or catheter-directed thrombectomy? And how do we decide? Well, before we start with that, let's talk with the scope of the problem. We know that 1 in 4 people worldwide are dying from conditions caused by thrombosis. And in fact, over 900,000 men, women, and children in the United States are affected by PE each year, and 100,000 of them are dying from them. And in fact, more people die of PE than breast cancer, car crashes, and AIDS combined. It's also the #1 cause of preventable deaths in hospitalized patients in the United States. And that is a remarkable statement to make. And the cost every year for VTE care is between $7 and $10 billion a year. It's a remarkable amount. And this problem is not going away. Now, fortunately, our population is living longer, but older age is a risk factor for getting a venous thromboembolic disease. In your 20s, your risk of getting a VTE is about 1 in 10,000. In your 80s, it's about 1 in 100. We also know that obesity and active cancer are significant risk factors for developing venous thromboembolic disease. And you can see here, those are on the rise. And the other important issue or factor about PE and DVT is nobody is immune. The youngest to the oldest to the most out of shape to Serena Williams, arguably the most fit female athlete in the world, has had 2 PEs. Jerome Kersey died of a PE after knee surgery. And Chris Bosh had to give up his career with the Miami Heat after his 2nd DVT. And you may remember NBC correspondent David Bloom died of a pulmonary embolism. The rapper Heavy D died of a PE. The actor Jimmy Stewart. And you may remember David Andrews was out for a season with the Patriots when he got a PE. And you may remember a year ago, an astronaut in space had a DVT. So nobody is immune. Now, when we think about the risk factors for blood clots, we think about hypercoagulable states, venous injuries, stasis. And one category of stasis that you might not be familiar with, which I think is on the rise, is gaming. We're actually now seeing young people who are spending hours in front of their consoles playing. A gamer died after playing World of Warcraft for 19 hours straight. And there's actually ongoing investigations into these deaths. So why do we worry about PE? Well, it's fatal within 1 hour after the onset of symptoms in about 10% of cases. An untreated PE mortality rate is about 30%. Now, the good news is if you're not straining your heart, your risk of dying of a PE is pretty low. However, if you are straining your heart and you're hypotensive, the mortality rate is much higher. So this is from the iCooper registry back in 2006. And they looked at the number of people who died at 3 months from a massive or high-risk PE, which means that they had a systolic blood pressure less than 90 for more than 15 minutes. And you can see here that rate is 52%, compared to 15% if you did not have massive PE. Now you may say, this is from 2006. Don't we have better therapies and interventions, all these new advances? And I would say, yes, we do. But these numbers are not changing fast. In fact, we looked recently at our own data, and that number, that 3-month mortality for massive PE, is still high at 41%. Now, it's not just mortality that we worry about, it's also morbidity. And probably the most severe form of PE morbidity is chronic thromboembolic pulmonary hypertension. This is something Vic knows well. And high blood pressure in the lung arteries caused by the blood clots and scarring leads to significant shortness of breath that can be life-altering. So how can we prevent mortality and morbidity associated with pulmonary embolism? Well, obviously treatment. So what are the treatment options? Well, there's a lot. We can do systemic lysis like a clot buster. We can do catheter-directed thrombolysis. We can suck the clot out. We can cut the clot out. Sometimes people need adjunctive therapy like an ECMO support, or sometimes they need a filter. And then of course there's anticoagulation. So how do you decide? Well, we know that the mainstay of therapy is anticoagulation. And this was one of the first and only randomized published trials in 1960 that compared anticoagulation to no anticoagulation therapy in patients with symptomatic PE. It was a small study, but rather pioneering, and has been referenced many times to support the claim that anticoagulation reduces mortality. They initially looked at 35 cases, and then they completed the series with 73. And you can see here that 5 of 19 patients that did not receive anticoagulation died from their PE, versus 0 of the 54 people that did receive unfractionated heparin followed by warfarin. And this proves that anticoagulation saves lives. So anticoagulation saves lives, but early anticoagulation saves lives. This was a study of 400 consecutive patients in the emergency room. All had radiographically confirmed acute PE, and they were either started on unfractionated heparin in the emergency room or after admission. And you can see here very clearly the patients who received heparin in the emergency room versus the patients who received it after admission had a significant lower in-hospital mortality as well as 30-day mortality. So this study clearly demonstrates an association between early anticoagulation and reduced mortality for patients with acute PE. So the question arises as to who needs treatment beyond anticoagulation alone. And that leads to the advanced therapies that I was talking about earlier. And that really depends on risk stratification. So what is your risk of dying of a PE? And you can be high risk, intermediate, or low risk. It used to be submassive, massive, and low risk. So if you are at a high risk of dying from PE, that means that you are hemodynamically unstable, that low blood pressure, and that you have clear strain on your heart, RV dysfunction, and cardiac biomarkers. And these people clearly need something beyond anticoagulation. They need primary reperfusion. Now, the next risk category is intermediate risk. There's high risk and low risk, intermediate high, intermediate low. Now, these people, their blood pressure is fine, but they are showing signs of strain on their heart, right ventricular strain, either on echo or on CT scan, or an elevated cardiac troponin, cardiac biomarkers. So intermediate high is when they have evidence of right heart strain on both of those modalities, and intermediate low is when they have evidence of right heart strain on just one of those. And those people definitely need anticoagulation, and there are a subset that may benefit from rescue perfusion therapy. And then we have low risk. Those are the people whose blood pressure is fine and they have no evidence of any strain on their heart. And those people need anticoagulation and oftentimes can be discharged early. So where does our patient fit in? Well, she had RV dysfunction, both on echo and on her CT, and she had elevated cardiac biomarkers. So she is definitely intermediate high. So how should we treat her? Well, let's look at the guidance. These are the 2019 European guidelines. And you can see here that, of course, somebody has acute PE, you start with anticoagulation. And then let's look at her, intermediate high risk. What else should we do? Well, it says monitor and consider rescue reperfusion if the patient is deteriorating. What about the American Heart Association? Similarly, intermediate, you should anticoagulate. And you should favor an intervention if the patient is deteriorating, if they're in severe distress, maybe if they have a clot in transit, or severe or persistent right ventricular strain. What about the PERT Consortium? We actually came up with a consensus practice, diagnosis, treatment, and follow-up, and very similarly, anticoagulate anybody with an acute PE, as long as there's no contraindication, and for that intermediate high risk, consider some kind of advanced therapy. So all of these guidance suggest consider an advanced therapy if patients are deteriorating or if patients don't look good, but how do we decide that? And really the best treatment is unknown. There's really a lack of high quality comparative data. Now we have had rapid advancements in interventional tools over the past 10 years, but there's varying and conflicting guidelines. And that was really the impetus for the pulmonary embolus response team. So I'm going to show you what it looked like at Mass General before we started PERT. So severe PE could be identified either at MGH or a referring hospital. And the way patients were treated really depended on who got called and where they were in the hospital. There was no coordination of care. It varied by medical service and location. There was no consistency in decision making, and there was really no single team and no acceptable algorithm. And there was really no systemic way that we were evaluating our results. So after the PERT was developed, now we have somebody with a severe PE identified, our PERT team is activated, and we have an immediate conference call with multiple specialists to talk about the case and decide what is the best therapy for this person. Is it anticoagulation alone, or do they need something else? And if they need something else, what is that? And then we mobilize the resources to make that happen. So really the mission of PERTs was to advance the diagnosis, treatment, and outcomes of patients with severe PE, and really to become centers of excellence in the science of PE care through multidisciplinary collaboration in clinical care, education, and research. So I'm going to describe our PERT, but I just want to point out that every PERT is different, and it's really going to depend on the needs and resources of the institution. So at our hospital, a PERT can be called from the emergency room, on the floor, or even the outside hospital. Our PERT fellow gets pertinent information to decide whether or not this patient is one of those low risk, submassive, or intermediate, or massive patients. And the threshold for activating a PERT is going to vary among institutions. In general, patients who are the intermediate risk and high risk, where the clinicians is not really sure if they need to do anything else beyond anticoagulation, those are the people that warrant a PERT consult. And these uncertainties and controversies, especially in patients with the intermediate and high risk, are what drive the need for PERT. So if PERT is activated, we have a multidisciplinary team. We immediately have an electronic meeting where we simultaneously, in real time, all get together and hear about the case. And then we decide, does this person warrant more than anticoagulation? And if so, what? And how are we going to make that happen? On discharge, all of our patients follow up in our multidisciplinary follow-up clinic. So in order to publicize, we have posters around the hospital displaying the PERT activation number, which is for PERT, and it describes the indications for activation. And we have an easily accessible response triggering system that consists of a 24-hour emergency activation line for PERT. We immediately have a page and email that's sent to us simultaneously, and it will say PERT call in 10 minutes. Now, this is not something you can do in 3 days. These people are severe PE, and seconds matter. So we immediately will have a conference call where we can see the images, look at the labs, hear the case, and decide together what the best form of therapy is for that patient. Now, MGH is a little bit of embarrassment of riches, I'll say. These are the people that are involved, or specialists, I should say, involved in our PERT team. We also have nursing, and oftentimes we will have a patient or family member join us. And I know we have 11% of patients on the call here, and we encourage patients and family members to get on those phone calls and hear about the conversation and be a part of it. And in fact, I'll give you one example. This was a woman who was out of state, and she needed to travel to Colorado to give a keynote address for her company. But she had started to feel short of breath about a week before she was supposed to go, and she was a little bit concerned. So she called her primary care doctor. She thought it was her heart, so she had a stress test. She actually passed the stress test, meaning she wasn't injuring her heart, but she was short of breath and had to stop in the middle. But nevertheless, she was told she could go to Colorado. So she got on an airplane, flew to Colorado, gave her keynote address, and was so short of breath that afterwards, all she did was sit in her room. She missed the entire conference. At the end of the conference, she got on an airplane, flew back home, and she was so tired, she decided not to do work on the evening she got home and instead turned on the TV. And on the TV was the show House. You may remember, I'm not sure if it's still on. And one of the characters on House on that day ended up having a pulmonary embolism. And she realized that she probably has a pulmonary embolism. So what did she do? She actually went to bed. And the next morning, she called her primary care doctor, who said, you immediately need to go to the emergency room, which she did. And the emergency room doctor, this was a community hospital, had actually heard one of our PERT talks. And he called a PERT consult. And we all got on the phone, and she actually got on the phone too, and we discussed her case. She was actually an intermediate high-risk patient, very similar to the one that I've presented. And we reviewed with her what her options were, and she decided to come to MGH. She got catheter-directed thrombolysis. She was admitted to the ICU and went home the next day. I see her once a year. This is about 5 years ago, and she's doing quite well. So it's really important, patients in particular, to be involved in your care and definitely be involved in these critical decisions. So what's the data behind PERT? So when we first started our PERT, we decided to start collecting data right off the bat. And the first thing is we wanted to see, are people calling PERT? And I think if I remember correctly, there might have been 7 consults that first weekend. But you can see here, every 6 months, the number of PERT activations increased by 16%. We then wanted to know if it was changing any outcomes. And remember, I told you that 3-month mortality rate for the massive PE was 52%. We actually found it to be 25%, so that's much lower. So the question is, does our approach improve outcomes? Well, I looked at the before and after PERT. So each dot or plus is a 6-month mark, and the blue was before and the red was after. And you can see here that clearly before we started PERT, death within 30 days for all patients that came in with a PE was on the rise. And after PERT, you can see here that it was certainly trending down. Now, since then, there's been a number of pre and post PERT studies. These are just a few, and I don't have time to go through all of them, but I will highlight a few. So this was a study out of Rochester of 305 patients. And they found that after PERT, there was increased efficacy and utilization of advanced therapies. So what they looked at is triage to diagnosis, and they found a 45% decrease in after PERT. And then they looked at time to heparin initiation, and they found it was a 58% decrease after PERT. And then they looked at disposition, whether the person was being admitted or sent home, and it was a 26% decrease. So this analysis clearly shows that following PERT implementation, patients in the emergency room received significantly expedited care. They also found that there was an increase in the utilizations of advanced therapies. Pre-PERT, heparin is in the blue, and post-PERT, you can see that there were many more advanced therapies. Now, this is a study out of Cleveland, and this was 769 consecutive patients with PE. And when they looked at before and after, there's on the top part is this entire cohort, but I'm going to focus on the intermediate high risk because I think that's where a lot of the questions are. And you can see here that after PERT, the time to therapeutic anticoagulation was significantly less than before PERT. You can see less people got inferior vena cava filters. There was less bleeding after PERT. And look at this, the 30-day mortality was 5.3% in this population post-PERT versus 10% in pre-PERT. Now, not all of the studies are showing improvement. This was a study out of Boston, and it compared 884 patients before PERT and 1,158 patients after PERT, of which 14% were evaluated by PERT teams. And they actually found that there was an increase in advanced therapies, thrombolysis and catheter-directed therapy after PERT, less IVC filters, but no difference in mortality. But they did find that there was an increase in risk assessment being done in post-PERT patients. So that's very interesting that more people were being assessed based on their risk. There was also, like I said, increase in catheter-based therapies, but no difference in mortality. This one was just published a little bit ago. This was at the University of Kentucky, and they looked at 226 pre-PERTs and 304 post-PERTs. And they found that in-hospital mortality was less post-PERT, after PERT, that length of stay was actually less, and any time on mechanical ventilation was also less. This study also found that the total cost of care decreased after PERT. So the implementation of PERT really improved the quality and cost of care in this study. What about the impact on trainee physicians? This was a wonderful paper. It was actually a survey of 73 participants who self-reported on improved understanding of the pathophysiology and management of high-risk PE after PERT. And 83% of these trainees felt that PERT improved the care of patients with PE in that institution, and 83% reported that PERT had a positive impact on their education. So, should everybody have a PERT? Well, we've actually been recognized by the European guidelines. So in less than 5 years in existence, the European guidelines are actually suggesting setup of PE response team is encouraged as they address the needs of modern system-based healthcare. And you should have different disciplines, and you should convene in real time, and it really enhances clinical decision-making. And in fact, they highlight the management of high and intermediate risk patients should be considered for having a PERT. So, even though this started at MGH, other institutions around the country started to develop their own PERTs. And we actually came together to form the PERT Consortium, whose mission and goal was to really improve PE care worldwide through clinical care, education and awareness, and research. And we have become a global entity. So we started in May of 2015. That was the first the PERT Consortium meeting for 90 providers representing 30 sites. And now there are hundreds around the world. And I don't think we ever imagined the global impact of the concept of PERT that this consortium would have. And this year, at our scientific symposium, at the end, we actually had over 900 registrants from over 33 countries. And this clearly reflects the level and enthusiasm for PE on a global level. And this is phenomenal, especially during this very challenging time of COVID. This is the list of the hundreds of institutions that were registered from around the world. We had an incredibly diverse group of people from multiple specialists, and we all came together to learn from each other and to share ideas. And it's really an opportunity to collaborate with people around the world. So I don't have time to go through all of the programs and projects that the PERT Consortium had. That could be like a 3 or 4 hour webinar, but I will go through a few of them to just highlight what is available and why you should get involved. So we have a webinar series, and so once a month we'll have webinars. Now, obviously around this time, we focused a lot on COVID, and I'll highlight our most recent one, which was a debate where we had experts debate the most challenging, probably controversial question right now, which is COVID patients who are hospitalized, should they be given more than just prophylactic anticoagulation? And it was an incredible debate. It's actually on our website, you can listen to it. We also have PERTinent Updates. We realize that people are busy and they don't have time to read and try to figure out what the most important articles on PE are every month, so we provide that for them. So every month, people get a newsletter that contains 5 to 10 of the most important PE pieces and manuscripts that have come out. It has guidelines. We also have a section for upcoming trials, so PERT institutions can involve themselves in that. And at the bottom, we have, if PERT members have actually published, they have a place to actually share and highlight what they have done. We also have podcasts that are called PERTcasts. This was about DOACs and VTE, but I encourage you to go on the website. There are many. And they're just about anyway ranging from 10, 20 minutes on really all of the important topics that have to do with PE. Actually, Vic is in a lot of them, I believe. We also have something called PERT Partners. So we know that a lot of institutions are thinking about starting a PERT, and we partner them with an institution that already has a PERT that's up and running to help guide through how to start a PERT. We partner with World Thrombosis Day to increase awareness programs. We're working on clinical tools and decision programs and possibly a PERT app. Connecting with other PE groups like this, being sponsored by the National Blood Clot Alliance. And there's the Anticoagulation Forum, and there's NATF. We also really want to focus on patient education, awareness, and prevention. We have 2 projects that are being sponsored by some of our industry colleagues at Transitions of Care Project and an Inter-Hospital Transfer Project. We know that when patients leave the hospital and go home, that's where a lot of care can get lost and that continuity. And then the Inter-Hospital Transfer Project, we know that there are some places that may not have the same advanced therapies that other institutions have. And so we're trying to figure out how to give care and provide care for everybody consistently. So we're trying to increase visibility with Twitter, Facebook, and the website. You can see here, this was tweeted out. And after our scientific symposium, we had over 1.5 million impressions on Twitter. It's just incredible. We have a clinical protocols committee, and they came up with a consensus practice document on the diagnosis and treatment and follow-up of acute PE care. And this is very comprehensive and very helpful. Now, when COVID hit, we thought we really need to help people decide and know how to diagnose and treat PE during COVID. So we came up with a position paper. And this algorithm represents how to treat patients in high volume COVID institutions where resources may be limited. In this setting, if you have a high clinical suspicion for PE and you're unable to obtain imaging, that is the situation where you should consider therapeutic anticoagulation. I've already shared with you that anticoagulation saves lives and early anticoagulation saves lives. So this is in line with those discoveries. So there's a lot of publications on PERT. I actually looked at 2016, there were 20. 2017, there were 39 total. 2018, up to 63. 2019, 86 publications. 2020 were 128. And so far in 2021, now this is cumulative, is 142. Now the limitation of all these publications is that they are single center reports, and they really lack prospective controlled studies to really evaluate the benefit of the PERT concept. So given that how prevalent PERTs are today, I doubt we could do a randomized control trial today. You can have a PERT, you can't. But if we could bring everybody's data together, we could learn so much, and that is exactly what we did. So I would say that one of the most exciting endeavors over the last 2 years for PERT has been the creation of this multi-center registry, the PERT Consortium Quality Database. And in just over 2 years, we actually have 5,000 unique patients, not 4,000, from 33 sites across the United States. And just to give you this perspective, remember the iCooper registry that I mentioned, that I showed earlier? That was from 20 years ago, and it was 52 institutions and only 2,500 patients. So we've already surpassed that. And it's really due to the incredible effort of all those sites. This may even be the largest modern database in the world recording outcomes just with PE alone. So if you're interested, please go to PERTconsortium.org and look this up. So here is who is participating in the database right now. We have both academic and community hospitals, but we're not as diverse in geography yet. You can see here we are very heavy on the East Coast, but we're really lacking in the West and the Midwest. So we are looking for members. Now to review briefly, each site gets a dashboard 4 times a year with their own data as well as the national average. So I'm just going to share the national average. And it's important to remember that this is not a database of all PEs in your institution. It's a database for whom the PERT team was activated. So these are really the sicker patients, and the patients for where there's not really a clear-cut answer on how to treat them. Like our own patient, and not surprising, 54% of patients in this cohort are intermediate. We have 12% high and 12% low. And I just want to point out we have 20% not reported or missing, and I think that's a huge quality opportunity. I also want to share with you anticoagulation. This shows that just about over 50% start anticoagulation prior to their PERT activation. Now this has definitely drifted up over the year, but remember how I showed earlier how important early anticoagulation is. So this is another great opportunity for quality to improve quality. And the power of the database is really to positively incentivize sites and get people to work together and improve outcomes. As I shared with you earlier, one of the associations with VTE and obesity, and you can see here in terms of BMI, that 50% of the people in this cohort have a BMI greater than 30. So this is turning out to be a fairly significant risk factor for PE, and this opens up a ton of potential questions that we could ask about this risk factor. This is the use of advanced therapy, including combination by risk category. You can see here in the high risk group, not surprising, that most of those people got anticoagulation, but also some form of advanced therapy. Low risk, most of them got anticoagulation, and very little got advanced therapy. And then this middle group, most of them got anticoagulation, and there were some people that started to get advanced therapy. In fact, just over 20% got catheter-directed therapy, and less than 10% got anything else. So what about mortality? Well, you can see here, high risk at 30 days was 25%. This is very similar to what I showed you with the MGH data. But I want to point out this intermediate risk. And you can see here for the intermediate risk, the mortality rate doubles from 30 days to 1 year. And we don't really understand why that is and what is going on. And we really need data in this area. And it raises the question as to whether we should be escalating care in some of these intermediate risk patients. We don't know. And the stats may help us identify which cohorts are really at the highest risk of dying. And that may help us identify who needs to get rescue therapy. I have to say, this is such an opportunity to potentially save lives. I just want to go back to the 25% and the high risk. So certainly we're doing much better than 20 years ago, but we have still much work to do. So how can you get involved? Go to PERTconsortium.org, join or start your own PERT team, join and start entering patients into the database. You can join committees and projects, and definitely come to our next PERT meeting. This is going to be the 7th annual PERT Consortium meeting and scientific symposium. Our business meeting is going to be October 7th, and the symposium is 8th and 9th. This is going to be in Boston. Hopefully it's going to be a hybrid. The other thing is the fact that you are watching this now, you are actually taking part in VTE Awareness Month, which is March. And I also encourage you to be cognizant and celebrate World Thrombosis Day. I will tell you, every year on October 13th, we have a big table in the middle of the lobby of Mass General to raise awareness about deep vein thrombosis and pulmonary embolism. And I kid you not, a few years ago, we actually diagnosed 2 DVTs on the fly. We had one man come up to us and said, "What is the DVT?" And we started to tell him. He pulled up his pant leg, and his leg was red and swollen, and he told us it was painful. So we walked him over to the emergency room. He was actually diagnosed with a DVT. So very important that we raise awareness. Educate your patient and providers. And as World Thrombosis says, don't wait until tomorrow. Open your eyes to thrombosis today. So going back to our case, so she was a high intermediate risk PE, which likely originated from her left lower extremity DVT based on her clinical history. Luckily, she had her head imaging, which was reassuring. She did not have any bleed. And anticoagulation saves lives, early anticoagulation saves lives. She was expeditiously started on low molecular heparin, and the PERT team was called. And we thought about, where does she fit in and what should we think about? Well, we were kind of concerned for a few reasons. One is she had many high-risk features. Her EKG, she had her troponin, which was showing us that she was straining her heart. She had strain on multiple modalities, on echo and CT. She was persistently tachycardic, her heart rate did not come down, as well as tachypneic. She also had very large proximal thrombus and a saddle PE, and she also had syncope, meaning she had passed out, and we know that that can be associated with worse outcomes. So we talked about what the options were, and we actually talked to her about what the options were, and we decided together that she should do catheter-directed thrombectomy. And here is our cath lab, and here is her pre-CTA, and here's her PA-gram. So essentially what this is you should see, if you haven't seen one of these before, these are her vessels. And you can see that they're not black. They should be filled, they should be black, which means there's flow going through there, and there's very little flow going through there. And after the procedure, you can see clearly that she has significant flow, and we've restored her perfusion. And here is what her clots look like. So she was diagnosed 3 days later, and her additional workup did actually show that she may have May thirders. And so the importance of follow-up, that every patient should have a follow-up when they leave the hospital. So my closing reflections are that PE is a major cause of morbidity and mortality. And PE represents a paradigm shift in treating pulmonary emboli. It's in real time, it's immediately and simultaneously engages multiple experts to determine the best course of action. And it streamlines multi-specialty care and communication, which is critical in the management of acute PE. It can also ensure outpatient follow-up. PERTs have become prevalent across the United States and the world in the last few years. And they're now recognized by many guidelines, including European guidelines. Do they improve outcomes? I shared some data that said yes and some that said no, but we need more data. And that's where the PERT Consortium comes in, whose mission and vision is to really improve PE care worldwide through clinical care, education, and research. Our quality database has already 5,000 unique patients, and we're looking to answer relevant questions regarding optimal care for these patients. And also, the PERT Consortium can serve as a platform for large-scale PE registries and trials. I shared with you upcoming events and how you can get involved. As Helen Keller says, alone we can do so little, together we can do so much. Please join us at the PERT Consortium. Please go there to find information. Thank you very much for your attention.
Rachel, that was great. I can hear about 1,000 people applauding right now. It's a really good lecture. Very calmly and so you covered so much in a short period of time. I love the story about House. That was great. And I love that was great. I love your comment that no one's immune, because we focus so much on risk factors, but really we see PEs out of the blue, and you got to be aware of symptoms and signs and risk factors. Really a great job. Well, we're going to shift to the question and answer section now of the webinar. So again, to submit a written question, please use the question area of your toolbox there. And I know we're going to have a lot of questions up for you. I'm going to read the questions aloud. We'll get as many as we can.
Okay.
And let's get rolling. Rachel, let me start with a quick one as I start to look at the question here. So what about follow-up? We focus a lot on the initial management. What about follow-up? Can you just give us just a quick blurb on your thought there?
Yeah, so you know, when we started PERT, it was about 2 years into PERT that I realized, wow, these people are getting this incredible, rich experience in the hospital. All these people are thinking about them, and then when they got discharged, it was like, well, who's following them? And we didn't have that same kind of multidisciplinary approach to them. So we started a multidisciplinary follow-up clinic at MGH. So we have hematology, cardiology, and pulmonary. We do that twice a month. And before COVID, we would meet between 8 and 9 and go over all the cases and then see the patients. And I think follow-up is critical. First of all, people, you know, in the hospital, I think, and there's a lot of patients on the phone right now or on the webinar, you know, there's so much information you get, and I think you remember and retain maybe 10%. So the first thing is people just want to tell their stories, and they often want to know, like, why did I get my blood clot? So that's the first thing, just let them talk. And then you really want to make sure they have appropriate age-appropriate cancer screening, make sure they're up to date that. And any abnormalities that were in the hospital, I actually had a patient that was anemic. He came to see me in follow-up a month later. He was still anemic, and I did a workup. He actually had multiple myeloma, so important to do that. And then I think really important to talk about the patient's treatment. What dose are they on? Do they understand how to take it? Are they able to afford it? Are they being adherent and compliant to it? Talk about avoiding, you know, non-steroidals and aspirin, avoid high bleeding risk situations, and really important for patients to tell their providers about any procedures that they might have. And then, you know, how long does the patient need to be on the medication? That's probably one of the most important and pressing questions patients have. Do I need to be on this for a long time? And also the concern, if I go off, do I ever need to go back on it again? And then that follow-up also allows, remember I talked about that CTEF, which you are an expert in, it really allows you to ask questions and find out if patients still have symptoms. Are you still short of breath? Now we know there's this post-PE syndrome where people continue to have shortness of breath and fatigue and exercise tolerance, and even decreased quality of life. And you, I don't know what you found, but I find at the 6-month mark, people are kind of like, oh, I finally started to feel better. But we do worry about CTEF, so it's a time to ask about that. And if they have like an abnormal echo, make sure that we check that. If they had an IVC filter, it's a perfect way to make sure that that comes out. And then, you know, obviously, if people are smoking, if they're overweight, we can talk about that. And then probably something that is not talked about, and I don't think there's a lot of literature on this either, but something that I'm really excited about learning more about is kind of the post-thrombotic stress disorder, where there's a lot of anxiety. I actually had a patient who passed out. She woke up in the ambulance, and you know, because of her PE. And for a whole year, every time she heard an ambulance, she had a panic attack and ended up back in the emergency room. So luckily we got, you know, she agreed to have a therapist who did a little cognitive behavioral therapy, and now could listen to an ambulance go by. So I think follow-up is critically important, and having a PERT, it flows very nicely. You've got the PERTs in the house, and then you have a follow-up. And really, you know, the way you do your follow-up is really going to depend on the needs and resources of your institution. I know you have a follow-up, right?
We do, Rachel. We do. We have a PE clinic. We channel a lot of our folks into our pulmonary clinic at Cedars-Sinai. So we have, I don't know how many now, but certainly more than 1,000 patients that we've seen over the years in our PE clinic.
Yeah, and I will also say that I didn't share this, but one of the slides from the database is that just under 50% of PERTs actually have patients follow up with a dedicated PE specialist. So I think that's another opportunity for quality improvement.
Agree, Rachel. It's hard for I really envy family practice folks, internal medicine people. They have to know so much, and I do think there's a lot. Research is moving so fast. There's a lot in this field to know. So I agree that specialists are important here. There's a ton of questions, Rachel. A couple of quick ones. One just so everyone knows that someone asked if they can get access to slides. And this program is going to be archived. The webinar will be archived. The content will be available at the CDC's Division of Blood Disorders website, and we'll show a slide of that. There's a number of questions. Some are very PERT related, and some are I can't get to them. One that's very PERT related right now, Rachel, is there a study to evaluate with a minimal number of cases per day per week that requires the creation of a PERT? I mean, do you have to have a certain number of PEs to start a PERT?
So that's a really good question. So I didn't share this, but there is a definition of PERT that we came up with. Actually, I think you were involved in coming up with it too. So the definition of PERT is an institutionally based multidisciplinary team that has easy to access and has the ability to rapidly evaluate and provide treatment options for patients with acute PE. They have a formal mechanism to exercise kind of the full range of medical, surgical, and endovascular therapies. They can provide appropriate follow-up, expert follow-up to evaluate patients, and when feasible, collect and evaluate and submit data. So, but what I would say is, what we're finding with our interhospital transfer project is that, there's some institutions that just don't have the resources that a larger institution might have. And so I would encourage anyone to go to the website and inquire about how you could start one, because I think at the minimum, you need more than one person who's a physician that's gonna be helpful, because it's multidisciplinary. So you gotta have at least two. And beyond that, I think it's, do you have the numbers, right? If you have, 1 or 2 PE a year, you can start a program, or maybe you're gonna, hook up with a PERT that's in your area, that maybe when you get that 1 or 2, you can call that PERT. So I think it depends on, what your resources are. And then I think when you're thinking about starting a PERT, the most important thing is you gotta have a champion. You gotta have somebody that is really interested and committed and compassionate, passionate about doing this. And then there's a whole lot of things. And like I said, we have the PERT partners, and we're happy to help anyone that wants to start a PERT. But, thinking about give the data to support it, funding, give the administrative support, thinking about establishing guidelines of how you might want to activate, who are going to be the people that are answering the calls, who are going to be the people on the calls, who's going to do the procedures, who's going to follow up with the patients. Do you have an algorithm? Are you going to have meetings and decide what's working, what's not working? How are you going to let your community know that you exist? You've got to get the word out. And then, of course, research. You're going to look at what you're doing and see if it makes a difference. So I would encourage anyone, if you're a hospital that's seeing PE and you have more than one person that's excited and passionate about looking into this and helping to improve care, definitely reach out to us.
Great. Yeah, please come to the PE Consortium meeting in Boston. Whether it's hybrid or virtual, whatever, please come. It's a great meeting, great way to meet people from around the world that are interested in PE. It's a fun meeting. Well, Rachel, we've got another question here. And by the way, I totally agree that the PERTs can be somewhat variable. We get calls from the ED sometimes. They'll say, well, I've got this patient with PE. It's a small PE. Can I send them straight home? Or at the other end of the spectrum, of course, the massive pulmonary emboli. But like you mentioned, I think these intermediate risk PEs are the more troublesome ones. And we get all kinds of combination questions about bleeding. This patient had to bleed this time, that time, this place, that place. What can I do? Can I anticoagulate? Should I do more? So much. Rachel, what about the role of pharmacists in PERT? I mean, we find them incredibly valuable. What do you think?
Yeah, I think they're incredibly valuable. There's a lot of questions about, DOAC use, direct oral anticoagulant use, and heparin, and if you're going to give it advanced therapy, can you do low molecular heparin? Can you actually do a direct oral anticoagulant? What's the dose? How do you follow it? So we have a pharmacist, I think he's on, Russ Roberts is our pharmacist on, and just it's an incredible resource. And George Davis is a pharmacist. He's been involved in PERT since the very beginning. So I think they have a critical role because, they understand drugs in a different way than we do. And I would just put a plug for really all of the specialists. I'm a hematologist, and I think about PE before I joined PERT, before we started PERT, like a hematologist. And being in PERT has allowed me, I think I'm a better hematologist because I have learned so much from my pulmonary colleagues, cardiology colleagues, emergency medicine, radiology, interventional, vascular surgery. I think about it in a completely different way. So I think if you have the access and the interest of these people to get involved? Absolutely, because I think it's just going to make your program that much richer and stronger, and you're going to learn so much. I mean, I would say a week does not go by where I don't have one of my PERT friends call me about a heme question, probably at least once a week. So I just think, and you know, it's now worldwide. It's not just, you know, in this country. And so we're now, you know, there's PERTs in Ireland. I think they're going to be starting in London. In China, actually, you can speak to the China one. You know, China has about 250 PERTs.
Well, listen, Rachel, great. We've got a little bit more time for a couple more questions here. I'm posting your cell number up here because we're not going to get to all.
I thought you were posting your cell number.
One came up just, and this is a long, could require a long answer. What about the pregnant patient that comes? You get a PERT call for a pregnant patient. Do you involve, be kind? Are there any kind of bullet points, 1 or 2 bullet points about the pregnant patient, how you might treat them or start them, or what you would do?
Yeah, well, that's a really great question. So when you have a PERT, you're going to have your key people involved, right? So you're going to have your key players, you're going to have the go-to people. So every call, it's going to involve those. But you're going to have people, let's say the pregnant woman, or let's say it's a neurology patient that's bleeding into their head, or let's say an orthopedic person that's bleeding into their leg and had a PE. And so I would say absolutely, when we get a patient that's any specialist like that, we involve all of their people. So OB/GYN, we even get, you know, the pediatric people involved. So we've had many pregnant patients, as I know you have too, because we thought about writing this up. And it's, you know, it's different because you're dealing with a mother and the fetus and the lives of both of them. And you need to figure out what is going to, you know, save them both and what's going to be the least harmful. And it's scary. And, you know, where are they in their pregnancy? Are they early on? Are they later? You know, what is safe and what can we get away with? And so absolutely, it's imperative that you involve the specialist for that. So, and we actually, a fellow and I, a few years ago, actually wrote up a series and there's actually a case that we present of a pregnant woman who came in. And in fact, actually, that's how PERT started. Actually, so Ken Rosenfield, as you know him quite well, there was a pregnant patient that came to Mass General, and that was really the impetus that started PERT, because this woman was very sick. And Ken got lots of specialists involved all at once and realized, wow, this is really a good way to treat this. And they saved that woman. And that's really what was the impetus behind starting PERT.
Great. Rachel, you and Ken and Rich Chanik, Chris Cabral, so many. I should stop naming people because I'll forget people, but you guys did really I'll stop naming people. Really good, nice job. So a few more quickies. So what about this increase in mortality in submassive PE from 30 days to 1 year? You think that's comorbidities, Rachel? Do you think it could be CTEPH? What do you think it is? Any ideas?
You know, I really don't know, and I don't think we haven't dived into that. And that's one thing that really I think is we didn't expect that, right? You would think, you know, we know that your highest risk of mortality is usually in the first 3 months, right? Not in a year later. So I wonder whether or not something else like CTEPH, or maybe it's, you know, completely unrelated, but, you know, or maybe it's something like the PE that predisposed them, or maybe it's one of their comorbidities like obesity or smoking or something. We don't know that yet, but that's going to be an incredible opportunity for us to look into that and figure that out. And because I wonder, you know, is it people, you know, like our patient, she was intermediate high risk, right? And we just don't know. Like, would she have done just as well had we not done that intervention? We don't know, right? Because we didn't do that. But we do know that patients that are at that intermediate high risk are at a higher risk of having issues. But I can't, we don't know that answer, but I think that's going to be really important to look into. I don't know, do you have thoughts?
Yeah, my instinct is, and we got to finish up in a second here, Rachel. My instinct is that mortality just seems so low to me when I see our patients in clinic. And I was wondering, I mean, they come in, we follow them in clinic, and I see patients every in a couple of weeks, then I see them in 3 months, then I see them every year for the rest of their life, at least to check on them and make sure they're doing okay. We have research suggests, as you know, the Einstein choice study, the Amplify Extend study, that at 6 months, we can drop the dose of DOACs in half and continue it. Very low risk of major bleeds is protective. In the olden days, we either stopped early or we continued full dose. And now we've got these options. So it just seems to me mortality is low, but maybe cedar cyanide, I shouldn't say that, no. I think I think you're absolutely right. I think we got to explore this further. Boy, there's literally
And
hundreds.
I will just say that maybe PERT, maybe PERT is identifying and risk stratifying patients quicker, right? And maybe that's allowing us to intervene earlier. That might be, who knows?
Absolutely, yeah. So again, how can individuals out there get involved with the database, Rachel? Suppose someone's listening and say, gosh, I would love to enroll some of my patients in the database and be involved.
Yeah, so go to PERTconsortium.org. And I've already told our executive director, Michelle Lano, that there might be a lot of people that are looking there now. But if you are interested in joining the database, you need to join PERT, and then we actually have a whole database team that will help you with all the forms that you need, and we have a whole REDCap database that we can send you, a data dictionary. We can completely set you up to get that going for you. And again, if you saw that map, we're really good with the East Coast, and then we're lacking. Not that if you live in the East Coast, you shouldn't join us. And we also are really expanding beyond this country. So we actually have some people in Ireland that are starting to hopefully join our database soon. So go to PERTconsortium.org, let us know, send us an email, and we can reach out to you and have a meeting and set up everything that you'll need.
Great, Rachel. Well, we're pretty much out of time now. One more question I'm going to answer. I'll just answer real quickly for us. Can you please repeat the date of the upcoming PERT Consortium? So that's October 7 to 9. You can find it on the internet. It's going to be a great meeting. The last year was just fantastic. It'll be great this year. Well, Rachel, I just want to thank you again for doing such an amazing job presenting today and answering just tons of questions. I hope some of you that didn't get to hear things, or tell your colleagues to check out Rachel's lecture on the archives there, as we mentioned. But we really want to thank our colleagues at the CDC, the Division of Blood Disorders today, and the National Blood Clot Alliance also today for hosting today's webinar. Very shortly, you're going to get an email asking for feedback. So please respond to the comments if you can. If you have any additional questions about the presentation, you can contact Cynthia Sayers at csayers@cdc.gov. And that's one way to get any information you might need about the archive website. So thank you, Rachel. Thanks to CDC. Thank you out there. I'm so sorry we didn't get to all the questions out there. I humbly apologize, but there's more coming, and I hope we get to hear from you again before too long, Rachel. Thanks so much.
You. Real honor to kickstart the CDC's webinar, and really thank you very much for your attention.
You bet. Thank you. Thanks, everyone.